Okay, folks. So this presentation is about the management of pediatric paracetamol poisoning, especially the updated protocols that have come up in the last probably a few months. Something more in the research also coming up. So we'll be talking about the paracetamol poisoning from the traditional point of view, from the new evidences that have been coming up and been presented in research papers, and we would talk about some of the challenges of paracetamol poisoning as well. So this lecture is mostly focused on the overview of the NAC regimens that we use, the traditional ones and the new ones as well, and how we can tailor the different types of protocols for for personal use within the children's emergency department. We'll also talk about some of the adverse effects and how to reduce that with these new regimens, and obviously with that shortening the hospital stay for these teenagers. And also talk about some of the emerging biomarkers which are currently under investigation as a marker, surrogate marker of hepatotoxicity in paracetamol poisoning. So without further ado, let's start about all these things in detail. So I will give you a background first. So paracetamol is one of the most common poisonings, which is used as a tool of self-harm in UK. The overall statistics they say like it's more than 100,000 emergency department presentations every year. So the whole of UK sees at least more than 100,000, and this includes like people across all age spectrums. We in pediatrics we mostly see the teenagers, and this is one of the most commonest drug which is used as a tool of self-harm in the teenager group. Obviously, we are seeing some more, drugs being used for self-harm, like the antidepressants, especially the selective serotonin uptake inhibitors, also coming up. I think probably second to now to paracetamol, but still, paracetamol, wins the race when it comes to the drug which actually is used most frequently for self-harm, for suicide, for whatever a reason. Uh, and as I told you, that's more than 100,000 presentations to ED every year. Now, because paracetamol is a hepatotoxic drug, what we usually worry about is the damage to the liver in the form of acute liver failure, and they say in UK around 100 to 150 deaths because of acute hepatocellular failure because of paracetamol poisoning they occur every year. So despite all these treatments, NAC and everything, still 100 to 150 people they still die despite getting the treatment of paracetamol poisoning. One of the key aspects of paracetamol poisoning is starting the antidote, that is the N-acetylcysteine, within 8 hours of the overdose. And that's very, very important that we start it as early as possible. So they say like the talk space says within 8 hours. And there are challenges as well because these days there are different types of regimens, the 21 hours regimen and the 12-hour regimen and the few other ones that are coming up. And most of these regimens are to deal with the adverse effects of N-acetylcysteine. N-acetylcysteine is a very good antidote, but it also has got a very high adverse event rate in the form of bronchospasm, anaphylactoid types of reactions, nausea, vomiting, so on and so forth. They say like around like 20 to 25% of the patients who are started on NAC, they do suffer from some form of adverse effect. Though most of them they are not dangerous, but still that is a very unpleasant sort of an experience for these patients who already are undergoing something in the form of their mental health issues as well. So this is a little bit of the background on paracetamol overdoses in the UK. Now, talking about the traditional therapies that we have been using regarding N-acetylcysteine. So, by and large, I mean, most of the practice that we have seen, at least in my experience, we have seen the three-bag regimens, that is also known as the 21-hour IV NAC regimen. And if you see, it's usually these three bags. The first bag goes within an hour. That is, I think, if I'm not wrong, 150 milligram per kg NAC. That is followed by another bag which goes over 4 hours. That is, I think, 50 milligram. And then there is another 100 milligram which goes in the rest of 16 hours. So a total of 21 hours of and acetylcysteine. So obviously 21 hours mean that that child or that teenager stays for 21 hours at least. This is the minimum. Obviously it can be more than that, but this is the minimum. And during that 21 hours, he gets a total of 300 milligram per kg of N-acetylcysteine. It means like 150 in per kg in the first hour. You add 50 per kg for the next 4 hours. That makes 200, and then 100 for the next 16 hours. Like that makes it a total of 300 milligram per kg, which is given over 21 hours. Now, this has been used, I think, since these guidelines they came out in 2012, if I'm not wrong. And between 2012 and 2021 or 22, that has been the standard treatment of paracetamol poisoning. After that, there were a few other regimens that came out. We'll talk about that as well. So this has been very effective, but it comes at a cost, and that is a very high rate of side effects because we have to start with a very high dose of N-acetylcysteine, and that coincides at the same time with a high dose of paracetamol levels in the blood as well. So obviously, if you see, the bottleneck here is that on one level, that teenager has got a high amount of paracetamol, obviously a drug on a toxic amount, and on top of it, you are adding now another drug which acts as an antidote. But obviously, this antidote has got its own. So the body becomes quite overwhelmed. So the chances of side effects, they are actually increased. So the common side effects are nausea and vomiting, which obviously can happen because of paracetamol as well, or for that reason, any drug can produce nausea and vomiting. But it's more of a cumulative effect when you have got one drug which produces nausea and vomiting, another one which is also producing. Both of them are quite high in the initial few hours of the ingestion. So that's a very, very unpleasant experience for the patient. And it also leads to more of like asthma-like reactions, bronchospasm, and anaphylactoid reactions. I mean, it's not purely anaphylaxis, but something which resembles anaphylaxis in the sense. And again, that on top of the symptomatology, on top of the mental health issues and the low level moods, which usually most of these teenagers or children they are passing through, and on top of it you add that, things leads to a very, very unpleasant uh, experience. Another thing is that this regimen has been used across the board for adults, for pediatric patients, everybody, and this is like it's been a one size fits all approach. So irrespective, if somebody whose let's say paracetamol levels are slightly above the treatment line, let's say you do a 4 hourly paracetamol level, and somebody, let's say that 4 hourly, which is 100 milligram per liter levels, let's say somebody's got 105, you'll still give the same treatment. And somebody who has got 250 let's say milligram of paracetamol per liter, who also gets the same thing. So it's just like one size fits all. And again, somebody who has got no, let's say, underlying damage, I mean paracetamol levels are quite high, but let's say there is no acute hepatotoxicity at that point in time, gets the same treatment. And somebody who is suffering from hepatotoxicity in the form of, let's say, elevated liver enzymes and maybe a rising INR, they also get the same dose. So it's one size fits all, thing, which obviously was coming up in a lot of problems. It's still people ending up in liver departments and ending up in liver failure, some of them even needing liver transplant. So the thing is that this type of traditional regimen had a lot of issues associated with that, and then there was a dosing complexity as well, because when you got the 3 bags, they have to be prepared. Now ask any nurse and they would tell you how what a nightmare it is to prepare next solution. I mean, if you look the number of ampules that they have to break open to draw it, and then there is a whole way how much ampule you have to take based on the body weight, how much 5% dextrose or 0.9% saline that you have to mix into, and then setting up that infusion rate for 1 hour, and then when 1 hour bag goes in, usually you need to start a 4 1. So especially nurses in chat, they were very much sort of bogged down by these things when you have to give one bag, which usually goes in the children's emergency department. By the time they are shifted to the ward, another bag is being set up, and then that carries over in the ward, and then the ward nurses have to set up a third one. So there was a bit of logistic issues involved into that. And obviously, the more the logistic issues like setting up the bags, more the chances of having dosing errors in these things. So this has been the traditional regimen that has been used, by and large, across the length and breadth of UK, and these are some of the issues that were associated with that. So then, in the 2020 and 2021-22, then there was introduction to the new regimen. So some new regimens they were introduced, and obviously you can see in this slide comparison of the conventional, that is the 300 milligram 3 bags NAC regimen, which is given over 21 hours, and that is compared with some other ones. The recent one that is being promoted and we have started using it is that the SNAP regimen. I think the SNAP stands for the Scottish and Newcastle and acetylcysteine, because I think basically the research was carried over in these sites in Edinburgh and a hospital in Newcastle, where it was funded by the NHS, and they found out that the side effect rates was quite low as compared to the traditional. So we have got the conventional 300 milligram per kg, the one that still is there, but I mean, if you see, we have got in comparison, we've got a new one which is far better. That is known as a SNAP regimen, as I told you. Now, SNAP regimen also gives you 300 milligram per kg of N-acetylcysteine over 12. But the thing is that here, if you look at the timeline, if you look at the total duration over which this medication is delivered, that is like almost half of the traditional one. So the traditional one, where it goes over 21 hours, almost like you can say a full day. The SNAP regimen actually gives the same amount of dosing over 12 hours. Now, you will be asking, I mean, logically, if you think, you would say, okay, you are telling me that 300 milligram given over 21 hours produces more side effect, and you are saying 300 milligram given over 12 hours produces less side effects. I mean, doesn't it seem like counterintuitive or defying logic? How a medication, same amount, over a long term gives you more side effects, but over a shorter time period gives you less side effects. But again, uh, the details in the fine print. So if you see the first 2 hours, instead of the first 1 hour where you give 150 in the traditional one, and the SNAP regimen, what are you doing? You have increased this time from 1 hour to 2 hour, and you have decreased the amount of drug by 1/3. So instead of 150 milligram per kg body weight, now you are giving sorry, by decreasing it by 2/3, you are now giving 50 milligram per kg per hour. So that means like a total of still it comes out to be the same thing. If you 200 in the next 10 hours and 100 in the this, it comes out to 300. But the thing is that here you are going for less medication which is being given in the first 2 hours. So what happens? That you have got a high dose of paracetamol. Now you are introducing NAC, but you are introducing at a lower amount. So this lower amount of NAC is going to produce less side effects in the first couple of hours. Why? Because your paracetamol levels are so. This is going to sort of neutralize paracetamol, convert it into like sort of an inactive compound, and then slowly as the first 2 hours finishes, then you slowly gradually you increase the amount to 200 milligram per kg, and that's given over the next 10 hours. So again, if you combine this comes out to be a 300 milligram which is being given over 12 hours, but the frequency of the side effects decreases. So they say that where the side effects are around 20 to 25% with the traditional level, here it reduces around to 8 to 10%. So only 8 to 10% of the patients, they would be suffering some unpleasant side effects as compared to 20 to 25. Almost like you see the side effect profile is being reduced by one half. But SNAP is not only like it's 12 hours, it can be extended for another 10 hours, and that is known as the extended SNAP regimen. So SNAP regimen, which you see normally and you go to the talks base in an emergency setting, probably you're just looking at the first 12 hours. So you see, oh well, we have to give this for the first 2 hours and then follow it over the next 10 hours, which will be basically in the ward. But there is a third phase of that as well, which obviously is not used that much. It depends on the situation. Somebody who has got a very high overdose they probably would need an extended SNAP regimen. So you give the first one as like first 2 hours of 100 milligram uh, per kg, then 200 milligram for the next 10 hours, and after that you repeat the test. So let's say somebody has done a very high overdose, let's say maybe more than 300 400 milligrams of paracetamol per kg. So by that time, usually that's have got more chances of producing any hepatotoxicity or derangement in the liver profile. So by the end of the 12 hours, you would repeat the test and you would see whether the paracetamol level is still detectable, whether the liver enzymes are elevated, whether there is any arrangement of the INR. So let's say if the liver enzymes are raising again, they've got like cutoff levels for them. I will come to that in a moment. Then you can extend this the same dose for another 10 hours to make sure that the rest of the paracetamol or the high levels of the paracetamol are neutralized. So the SNAP regimen is, one is the traditional one is for 200 100 milligrams per kg for the first 2 hours, and then 200 milligram for the rest 10 hours. So 10 plus 2 is 12 hours. But if needed, where the paracetamol levels are quite high, usually 300 milligram and above, then you can extend it up to another 10 hours. And obviously that would be in the ward, probably never done in the ED. I don't know if on the adult side, maybe those patients who are under the medics, but still they are in ED for extended period of time. Maybe the third one, I don't know whether, but in pediatrics, I have never seen it because by the time they are on the second one, they are obviously in the ward. And if something happens for the third one, we don't know, it might be there on the ward. Australians have also have got their another regimen which is used in Australia, and that is known as the Australian 2 NAC regimen. So again, that gives you the 300 milligram per kg of an acetylcysteine. But what they do is they, instead of the first hour, what they do is they give 200 milligram per kg over 4 hours. So in 1 hour, it would probably become 50 milligram. So 200 milligram, that is given over 4 hours. And the next is reduced, and that is 100 milligram, and that is given over 16 hours. So that is like starting with a high dose and then reducing, as though as compared to the traditional, still, it's less, because if you see in 1 hour you are giving 150, here in per hour it comes across to be 50 milligrams. So like reducing it by 2/3. So still the chances of side effects, they are lessened. So what is happening here is that in SNAP regimen, on one hand, you are reducing the side effect profile of N-acetylcysteine, and the second thing is that if needed, you can extend it for another 10 hours if needed, especially in those people who have done a very massive paracetamol overdose. So at the moment we have got these three regimens. Basically SNAP, you can see you are seeing it as four ones, but basically the third one is an extension of the SNAP regimen. So if you open the Talkspace these days, you will see that down there are two ones, and they say if you are following the traditional 21 hours regime, calculate this way. If you are following the 12-hour regime, following this way. But recently, I mean, we have started in chat, we have started the 12 hours. Why? Because number one, the wards are more happy with this thing because it means less time on the ward. Obviously, pediatric ward in our hospital is quite overburdened because, obviously the number of beds is not that high. And they want that there should be quick turnover of the patient time so that patients are quickly seen, stabilized, and they go home. So somebody who's staying 21 hours on the ward, obviously it will be followed by CAMS assessment as well. So just imagine probably 2 or 3 days they will be staying up in the ward. With this one, at least the medical component of that is reduced to half of that. So the SNAP and the SNAP extended is the new regimen which is there on the Talkspace, and is, honestly speaking, that is the preferred one over the traditional or the conventional NAC regime. I hope you have understood this one in terms of what are the loading doses and what are the sort of a carrying over doses of these different protocols. So here it shows you in a more detailed manner this sort of algorithm If you go to the Talkspace is more of a text-based guideline. So probably you have to take a printout of all like 7, 8 pages, give it a read, maybe underline all those things. It makes the whole thing a bit easy because now it's giving you the same information in an algorithmic form. So obviously it's also based on Talkspace. So as I said, this if you decide to go with a 12 hours regimen, remember the first thing is that you have to know the body weight, multiply it by 100, and that would give you the total hours of N-acetylcysteine over the 2 hours. Then for the next 10 hours, you have to multiply the weight with 200 milligram to give you the total dose that has to be given over 10 hours. So when the nurses, they are calculating, they would like divide it by 10 to get the hourly infusion rate. Now, so once you have started this, usually the first 2 hours would be given in the children's emergency department. Rest would go into the ward. And let's say for information purposes, if this child for some reason is on the chin because he can't go up to the ward for whatever reason, and let's say the second bag which goes over 10 hours, that is also started over then and it finishes, then what we need to do at the end of 12 hours, so at the end of 12 hours we have to repeat the blood test. So we have to check the LFTs, we have to check the UNEs, and we have to check the paracetamol and INR level. This is very, very important because this tells you if you need to further go with a third bag or not. So let's say you repeat it and you find out that either the ALT, that is the alanine transaminase, or SGPT as some older books they call it, if that is abnormal, it's raised, or the ALT has doubled from the time. So obviously you when you did your 4 hours blood test, okay, so at that time you have got the liver profile as well. So you see what was the ALT at that point in time, and let's say if it was double, let's say the ALT was 50 and now it is 101, so it has doubled, let's say. But if it is, let's say it was 50 and now it's still 50, okay, so it's not increased. Or the paracetamol concentration is greater than 10 milligram per liter, that is mean detectable paracetamol. I think 9, our lab uses the cutoff levels of 9, okay, so anything less than 9 it will not show, anything which is more than 9, obviously 10, that is like detectable. So if ALT is abnormal or is doubled from the time of admission, or the paracetamol is detectable, then probably you will go for the third bag. That is, the third bag means the next same thing that you gave over the 10 hours, that has to be repeated now for another 10 hours. So the same thing, repetition of the second bag again goes over the same time. If let's say ALT is normal or is not doubled from the time of admission, or the paracetamol is undetectable, then you also look at the INR. Has the INR increased for more than 0.4 from admission or not? Because if it is increased, then you will have to repeat again the same, INR after 4 to 6 hours. But let's say the bloods are fine, the INR has also not risen, that is now medically fit for discharge. Medically fit for discharge means obviously they will go to the camps, because most of these, they have done self-harm overdoses, unless somebody did an accidental, but I don't think so accidentally somebody can like take 10 or 12 grams. Most of the times it would be self-harm or suicidal doses, so they can be discharged to camps for having a mental health assessment. But whosoever has got derangement of the liver enzymes, or paracetamol detectable, or INR greater than 1.3, they have to be given another bag of NAC. And again, with that, after the end of the third one, then again there is assessment of the same blood test once again to see if the child needs or the teenager needs another one or not. Because where there have been a few instances where the ALT has been running in thousands and the INR was like 7 or 8 and rising, so they have to be sort of a transferred, or like obviously after first or second or rare cases third, or what you'll do, these kids, they need to be transferred to a gastroenterology, like one which actually deals with liver, basically the liver ward, hepatology ward, where they can be put on some form of hemofiltration, because if still paracetamol, if the liver is failing, is not able to get rid of the paracetamol, then the only way to get rid of the paracetamol from the body is hemofiltration, basically. So they would need hemofiltration, some rest to see if the liver comes back. If not, some of them might be candidates for liver transplant as well. So this regimen, this SNAP regimen and the extended SNAP regimen, research has shown that it is basically non-inferior. Non-inferior means that it's not like inferior to the traditional one in preventing liver injury. So basically, the profile is the same, but the side effect profile of this is reduced as compared to the traditional ones. So this is a sort of a detailed, which called diagnostic algorithm, which actually tells you what to do when a child comes with acute paracetamol poisoning and you are going with the SNAP or the extended SNAP regimen. Okay, then when we talk about the extended one, like in the SNAP one, we were talking that okay, to first bag of 100 milligram per kg over 2 hours, followed by 200 milligram for the next 10 hours, and let's say even after that, the paracetamol is detectable. So then you go for the extended one. Now the extended one usually happens where you can get an idea if somebody, if you have done the 4 hourly paracetamol levels and they are greater than 300, probably that would be the patient who might need a third bag as well. I mean, not necessarily in all cases, but there's a very high probability that probably this child would need a third bag as well. And again, if you add this 200, so 200 plus 200 and the 100 that you gave, that makes a total of like 400 to 500 milligram. And obviously this is going over a prolonged period of time, but its chances are that it would reduce the hepatotoxicity from the extra elevated levels of paracetamol. And there was a special study which is known as the ATOM 2. It was an observational study in which they looked at the rates of hepatotoxicity in conventional as well as this higher dose regimen. So the conventional is your 21-hour treatment in which you give 150, 3 bags, 150, then 50, then 100 for any level of paracetamol. And these were the patients who had more than 300. So they were given this treatment. One cohort was given only this 21-hour treatment. The other one was given 2 hours plus 10 hours and then followed by another 10 hours. So they had a total of 400 to 500 as compared to 300 in the conventional. And if you see, there was a considerable statistically significant difference in the rates of hepatotoxicity in both. So the standard regimen, where they just gave the 3 bags of 21 hours, they had a hepatotoxicity rate of 27.7%. Every fourth patient developed liver failure, while in the high dose regimen, only 9.3%. That is almost one third of reduced hepatotoxicity as compared to the standard regimen. So this is quite superior when it comes to elevated, like mega toxic doses of paracetamol poisoning. So somebody who has taken, like let's say, taken 40, 50 tablets, okay, and consumed it, and obviously the paracetamol levels are, let's say, 4 hourly, or you've done it and it's like 300, 350, 400, something like that. So if you give them the standard regimen, these types of patients, the hepatotoxicity rates would be around 27, 28%. But if they are given the extended one, that is 2 hours plus 10 plus 10, still they are getting a high level of, but still on one hand, not only the side effects would be less, but the adverse effects in the form of liver failure, hepatotoxicity, would also be less as compared to the standard regimen. So obviously the ATOM study actually threw its favor in the what you call in the favor of this high dose regimen, the SNAP extended SNAP regimen, that it has got lower side effect profile and lower rates of hepatotoxicity as compared to the standard one. So again, this is a big case that the 12-hourly regimen should be used instead of the traditional 21 hours regimen. So Number one, how do we implement and what should be the clinical pathways? Number one, obviously we follow the talks-based guidelines. And talks-based, as I told you, is the obviously is the repository of the National Poison Information Services. It's present online. You just put your departmental, so what you call the username and password, and you just search for whatever you want to see, paracetamol in this particular case, and you get the whole thing. Okay, and you can click on the different links within that to give you the thing. What normally happens is that before you have seen the patient in chat, like traditionally what happens is the nurses have triaged them, and they have like asked how many tablets the child has taken, and then what they do is that they print or like all the whatever is written in the paracetamol section of the talk space, and they put you in the folder, and then you have to go through that, making mind, okay, what this is all about. The issue is sometimes what happens many times, especially for those doctors who are not that much familiar, obviously with practice, and if you're doing it repeatedly again and again, you develop it, like you've got this memory at the top of your head, so you know what you're going to do, what will be the next step. But sometimes some doctors who are new to chat, they might struggle with finding this information and what to do. So it's important that you have got something in the form of a like an algorithm which gives you an easy sort of overview of what should be your next step, rather than you giving it like a read, and sometimes you can miss the fine print. When to do the patient evaluation, what should be timing of the blood test. Okay, and again it depends. If you see, it's quite cumbersome whether the patient has taken medication in the, let's say, in the last 1 hour, whether the patient has taken medication acute overdose in the last 8 hours, whether he has done it more than, or whether it's a staggered overdose, like, and again then you are scratching your head now whether it falls within the first 8 hours. So it's better if all these things, what you need to do is if it's in the form of an algorithm. So a detailed guidance, like departmental guidance, needs to be made where in an algorithmic it tells you what you need to evaluate, what should be timing of the blood test, and how you should be administering all these things. Okay. Um, so this is like the basically the things that need to be implemented. We need to have a very crystal clear pathway, rather than every time making a printout and then studying it. Yes, another one thing is that sometimes what happens is that very frequently the guidelines, they even the fine print, it changes on the talk space. The problem is every time you open it, it doesn't tell you what has changed. So it might feel like you think that it's the same thing, but some of the finer print might have changed. Unfortunately, they do not sort of flag it like what has changed from the previous versions. That's why it's important that we, from time to time, like all these guidelines are evaluated by experts to see what has changed, and obviously that information is disseminated to all the doctors too, so that everybody's on the same page. So having said that, I will want to show you, like, this is the one that has been used, like it's for in use in the Newcastle Hospital. And if you see, they have made a very good, like sort of a 2 pages algorithm. It's like a chart that needs to be completed. They have got it for children over 6 years and for children under 6 years. Obviously most of them are over 6 years, so it's more relevant. So if you see, it talks about the snap 12-hour regimens. You can just attach a patient sticker on the top, and it gives you all everything. You just have to take mark and fill up the information. So let's see, it talks about the activated charcoal if the patient presented in the first hour. Okay, and whether the blood test, which blood test you have to do, because sometimes the doctors would come, how many bottles, which bottle do we need to fill for acute paracetamol poisoning? I mean, okay, do we just need to send the gold top or the, so it tells you like what bloods needs to be done. Okay, so all those things. So it just tell, okay, fine, UNEs, LFTs, INR, paracetamol concentration, and when it should be taken, ideally 4 hours from the time of last ingestion, things like that. And then it talks about, like, okay, from management point of view, how much acetylcysteine has to be given, how it is calculated, and everything. So it's a very good pictorial sort of a presentation of all the things that you need to do and how to interpret the blood test as well. So rather than going and back and forth to the printed version of the talkspace notes and seeing and trying to find out where the things were written and then underlining them, or like highlighting them with a highlighter or something. This is a very good thing. I think we need to make something similar on this pattern for ours. So like let's say somebody presents it, they just like grab this sheet from the one of the drawers, put a patient label on it, and then just you go through it. Just like we have got the same thing for diabetic ketoacidosis, like everything you just have to fill up, yeah, it calculates everything for you. The same thing over here. So, and you can put up the information as well quickly, like some of the blood tests in the tables below, and it gives you a good visual situational awareness of where this patient is in terms of his derangement of the, let's say, metabolic derangement occurring in paracetamol poisoning. So, and obviously you can, it gives you the paracetamol nomogram as well. You don't have to like, find it on the net and then see whether your levels are falling above or below that. So it gives you everything in chart. So we need to, the bottom line is we need to develop or maybe copy the same thing, just like change a few things with respect to our trust, and then implement it in our hospital as well. So just in a nutshell, this is something that just like helps in managing these patients, because you don't have to go back and forth, check the notes, look for it, everything is there. Also, I want to emphasize on a few things. This is actually research oriented. Probably it will take another couple of years before they come into practice. And that is about use of biomarkers. For the time being, when somebody has taken paracetamol overdose, we usually look at the liver profile. So you look at the liver enzymes. We look at the extrinsic pathway derangements in the form of prothrombin time elevation or INR, to see if that is raised or not. So that is one thing, because it's mostly focused on liver. Sometimes it takes a while before these derangements they occur. So obviously the liver is damaged, but it won't show up immediately on the blood picture. So you might think, oh well, fine, the liver enzymes are fine. Okay, nothing is wrong. I think I should stop the treatment. It's medically finished. But it might start rising later. So the thing is that it's not very sensitive. You can have like false negatives in between. So research has been going on to find out certain biomarkers which would be early indicators of liver damage, even when your liver enzymes and these coagulation profile is normal. And that is the MIR 122, HMGB1, and keratin 18. These are the different types of proteins which are basically analyzed. They're very much specific to liver, and in very early stages of liver damage, these, because of the drug, the way the paracetamol acts by sort of blocking your glutathione reductase pathways, what happens is that these levels they are elevated. So even at that point in time where you might find that the liver enzymes are normal, these markers might be elevated. So they are more sensitive indicators of early liver damage. So, and obviously when they are elevated, it gives you a picture that this probably child or this teenager is prone to develop hepatotoxicity or liver damage. So these types of proteins, they are still under research. They are being studied more, and for the time being they have shown very promising effects. So hopefully in the next like probably 4 to 5 years, we might have some like commercial blood tests to detect these proteins, along with the traditional methods of liver profile that we do, where it can indicate if somebody is more prone to develop. So this is one thing, these biomarkers, novel biomarkers. So research has been going on. Then they are talking about newer antidotes as well. So far we are using NAC. We are relying on NAC as the only antidote to paracetamol. But they say research is going on, and there have been an antiviral medication. I don't know how to pronounce this one. This is Gefodip something. I don't know. It's very difficult to pronounce these names. All these antivirals. Anyhow, so there is an antiviral medication which, for some reason, is quite good in blocking the effects of paracetamol as well. So this is also in research at the moment. And formepizole, you all know, is a medication which can be used in alcohol intoxication as well, basically used for that reason. But it's also under evaluation that it helps in preventing liver damage. Obviously, because the way the alcohol pathways they damage the liver, I think there is something similar between the paracetamol induced liver damage as well. So for some reason, the research has shown that fomepizole can also be used to prevent hepatotoxicity, but there is not enough data. Research is still going on, and maybe after level 3 or 4 trials, we might see if there is enough evidence for these medications to be used and change the practice guidelines. So, as I said, that these new antidotes, new biomarkers, they are being researched in order to come up with something new, which is more better than acetylcysteine, or at least can be, sort of, given as a complementary treatment along with an acetylcysteine in order to reduce the side effects associated with this one. And maybe in the future, integration might allow for more personalized therapy, where you would say if somebody's having this thing, they might be given some acetyl and acetylcysteine, and maybe a bit of fomepizole. Just like we talk about personalized treatment in asthma, we might be talking about personalized treatment in acute paracetamol poisoning. But just remember that the few biomarkers and novel treatments in the form of antidotes are being researched, and in another like couple of years, we might see something new on the horizon apart from N-acetylcysteine to treat these type of poisoning cases. Just to give you an sort of a hypothetical case scenario, like okay, so let's say a 16-year-old who, let's say, weighs 50 kilograms, and he has taken 10 gram of paracetamol. So he's taken around 20 tablets of paracetamol 500 with an intent to self-harm because he's suffering from mental health issues, feeling very down, has got depressive disorder as well, is known to the camps. And after taking medications, like in a couple of hours, he tells his friend that he has taken this thing and he's brought in an ambulance. So he's 6 hours post um, ingestion. So let's say he's already 6 hours post ingestion. So how let's say in this patient, the you have done the bloods, okay, and let's say you started him on treatment as on the meanwhile, and his paracetamol concentration came out to be very high, and he has got an elevated uh, liver enzyme ALT as well. So normally what we would do, like in this particular case, we will start him on the snap regimen. So the if he, let's say if he's 50 milligram 50 kilogram, so 50 times 100 would be his total dose, which has to go over the 2 hours, and then 50 times 200 over the next 10 hours. And then we monitor him, that is, by that time he would have gone to the ward. At 12 hours, they would repeat his blood test, looking at the ALT levels, looking at his paracetamol. That paracetamol should be undetectable by that time. Liver enzymes, if, as I said, like, if you had the initial value and they have doubled it, then probably the child would be candidate for the third bag. If not mild rise, then obviously you don't go for the third one, you'll just stop over there. But obviously he would need monitoring for the next 12 hours. And the important thing here is that to see whether this child would go from the snap to a snap extended or not, he needs to have these blood tests done at the end of the 12 hours to see if his paracetamols have been cleared off his body or not. So this is what, like, one hypothetical case scenario. Uh, then we have got, let's say, another one. This is a staggered overdose in a teenager, and let's say this is a 15-year-old teenager, again with a history of self-harm, known to the camps, multiple mental health issues, and he has taken a staggered ingestion over 24 hours. So he's been taking, like, 2 3 tablets every 1 or 2 hours, and let's say he has taken over 15 16 tablets in the last 24, let's say 30 hours. So normally what you do is, so in assessment, let's say you have taken the blood level, and usually these blood levels should be taken ideally 4 hours after the last ingestion. So whatever, because he's taken a staggered dose, so you need to know how much he has taken over the this 24 30 hour whatever, and you just also need to know what the last time he had his paracetamol. And 4 hours post that last, okay, you would need to take his blood levels, and you will check for the same levels, the paracetamol levels, liver enzymes, INR to suggest is any what you call is any damage to the so again this would be a candidate for SNAP treatment. And again, depending on the possibility of if he has taken a quite a huge amount, maybe it's not showing up like to high level at that point in time, but because of the liver damage or something, even if after the end of the 12 hours, if he still is showing paracetamol levels are detectable something, he might be a candidate for a third one. Very high chances that this child would go for an extended SNAP regimen. So this was all about the SNAP or the regimen, that is the Scottish and Newcastle uh, regimen, the 12 hours, also known as the 12-hour regimen of treatment of paracetamol overdose in pediatric cases. The Just to summarize it, it simply means we need to follow more of this profile because of its less chances of side effects. We need to develop a sort of a simple chart to help doctors in dealing with these cases, just like the Newcastle Hospital has made. I've got that, and I think we can simply copy it with a few alterations and print it, and it will be there. Like just like we've got the charts, we just like somebody comes up, then you just take that thing out and just tick mark it, and it will make things easy rather than doing everything, calculating everything yourself, and making yourself more error prone. And yes, and we should know that what needs to be done in case, like if these childs are staying on the jet for extended period of time, once in a while, let's say the ward is blocked or for any reason. So that's all about this acute paracetamol poisoning. Any questions now?